is Sarah Jane Shaw. I'm working with the Clinical Genetics Department here at Leicester. This podcast is about familial polyposis. FAP, or familial polyposis, is an inherited condition that has been linked to approximately 1 in 100 cases of bowel. FAP mainly affects the internal lining of the large intestine. It causes the formation of hundreds or thousands of polyps on the lining. Polyps are small, abnormal growths of tissue that is attached to the lining of the large intestine by a thin stalk. In FAP, these polyps are often called adenomas, meaning that they could potentially develop into a tumour at some point in the future if they are left and not removed. The polyps first develop during the teenage years, and if they are left untreated, people with FAP have an extremely high chance of developing bowel cancer by the age of 40. FAP is caused by a change in the genetic code. In the case of FAP, the change is found in a gene called APC, which in humans is on chromosome number 5. Everyone has 2 copies of the APC gene. They inherit 1 copy of the gene from each parent. In the case of FAP, only one of these copies needs to have an alteration in it for the condition to be present. This is known as an autosomal dominant condition. In most cases, FAP is inherited from a parent, passed on an altered version of the APC gene. Similarly, someone with FAP has a 50% chance of each of their children having the condition, as either the normal or the altered version of the APC gene will be passed on. If you are concerned that yourself or someone in your family may be at risk of developing FAP, there are methods of screening available. These often involve clinicians looking at the colon via a camera inserted through the rectum to see if there are any polyps in a procedure known as a colonoscopy. If any polyps are found, a sample will be taken and sent to a laboratory to see if the polyps are adenomas. This is obviously quite an invasive method, so if another member of the family has been diagnosed with FAP, it is often possible to carry out a genetic test to determine if the alteration in the APC gene can be identified. If a gene change is found, it is usually possible to offer a predictive blood test in the first instance for at-risk relatives to determine if they have inherited the altered copy of the APC gene. FAP in its early stages, pre-cancer, can often have no symptoms, but there are things that you, as a patient, can look out for when thinking about a diagnosis. These include abdominal pain, weight loss for no obvious reason, diarrhea or constipation abnormal from your usual bowel habit for more than 6 weeks, or blood in the stool. A medical indication or sign of FAP that a doctor may look for when thinking about a diagnosis is CHRPE, or congenital hypertrophy of the retinal pigment epithelium, also known as chirpy. This is a harmless condition that is effectively a spot of pigment change on the retina, similar to a freckle. It is quite rare in the general population, but as at least 50% of people with FAP also have chirpy, it can be useful when examining people with a family history of FAP or bowel cancer. Another condition often associated with FAP is the development of desmoid tumours. These are often considered by doctors to be benign, as they cannot spread far from their original location. They can, however, destroy some tissues that are directly next to them by growing into them, making desmoid tumours potentially important to remove, depending on their size, growth, number and position. After receiving a diagnosis of FAP, preventative surgery is often advised, as the likelihood of a tumour developing can be very high. The decision by the patient and the surgeon to operate is partly dependent on the number of polyps found, the individual's age, family history of cancer, and occasionally the precise details of the gene change. Certain medications can reduce the number and size of polyps in desmoid tumours may respond to anti-estrogen therapy. However, the high probability of one of the polyps becoming cancerous means that usually surgery is recommended. This involves removal of all or most of the large bowel before the age at which cancer usually develops. While this requires major surgery, it has been shown to greatly reduce the risk of developing bowel cancer. It is possible to surgically remove the polyps only, leaving the bowel relatively intact, but following this procedure, there is a high risk of recurrence. Depending on the type of surgery, patients with FAP should remain vigilant, as there could be a risk of what is left of the bowel becoming cancerous, so regular surveillance by a clinician is often recommended. Patients with FAP are also at a slightly higher risk of developing thyroid problems, so an annual thyroid examination should be considered. For the moment, surgery is by far and away the best treatment option for most people with FAP. It has a high success rate for the prevention of cancer. It is, however, highly invasive and disruptive, which is why the team based at St Mark's and the University of Leicester are continuing with their research into chemoprevention, so that hopefully, in the future, more options will be available to people with familial polyposis. In the meantime, if you have FAP and are considering having children, PGD is now available in certain licensed centres in the UK. PGD, or pre-implantation genetic diagnosis, is an IVF-related procedure where fertilisation occurs in a laboratory and the embryos are screened for the particular alteration in the APC gene found in your family. The embryos with the normal APC gene are then inserted into the womb. In this way, the condition will not be passed on to future offspring and the child will be unaffected. If you have any further questions about familial polyposis, please do not hesitate to contact the Leicester Clinical Genetics Department on 0116 258 5736. Thank you.